Good morning. We're going to start in just about a half a minute, so if you could please take your seats. Thank you very much. I'd like to begin with a very important public service announcement. And as you all know, we've had a terrific session this morning. It's a wonderful session tomorrow. But it's absolutely crucial that you are in the hall and in your seat before 9 o'clock, because the doors would close at 9 o'clock, and you will not be able to get in for the 9 a.m. session. So please do your best, get here on time, and definitely by 5 minutes of 9 o'clock, you are in your seat, and then the doors would close at 9 o'clock. No one will be allowed to enter after that time, but we all want to make sure that we get an opportunity to listen to Mr. Bill Gates. So please keep that in mind. My name is George Mensah. I'm from the National Heart, Lung, and Blood Institute at the National Institutes of Health, NIH, in Bethesda, Maryland. I'm delighted to be here. I was very, very fortunate about 15 years ago when I met Chris Murray when I was at the Centers for Disease Control and Prevention. And I can say without a doubt at all that of all the academic, scientific, and professional activities I've been involved in over the last 15, 20 years, the affiliation with the Global Burden of Disease effort has been one of the most important, most satisfying professional activities. I'm just delighted. And on this 20th anniversary, I want to personally thank Chris and Alan and the leadership of IHME for truly outstanding work. I should also mention, by way of full disclosure, that I have been a collaborator. I served as the chair of the cardiovascular expert panel for the GBD 2010, and I currently serve on the scientific council. But the work I do with the IHME has been approved as part of my official duties at the NIH. However, anything I say here should not be construed as representing an official position of the Department of Health and Human Services or the NIH. We had a really terrific session this morning, and we're going to continue with another terrific session. The primary purpose for this session is to have a discussion of the emerging population health challenges that the GBD faces, and to engage you in a dialogue about those challenges so that at the end of the session, the IHME and all of us would have gained a much deeper understanding of what those challenges are and how we might refine and expand data measurements, data sources, but also particularly the level of granularity that this work should proceed. I really want to strongly encourage you during the formal presentation, write down your questions and your recommendations and suggestions, and we're going to make sure we save enough time to engage you in dialogue. The way this is going to run, we have the time between now and lunch, and so the more efficient we get to be, the sooner we get to have lunch. We will begin with a formal presentation by my colleague, Steven Lim. Steven, as you know, is a professor of global health and director of science at IHME here at the University of Washington. He would begin with a formal presentation, and then my colleagues who would serve as discussants would take a few minutes, make some comments, and then we would open up to general for your questions, your suggestions, your recommendations, and your thoughts. There are going to be the 4 discussants, and we have Ritu Sadana. Ritu is a senior health advisor at the World Health Organization. She's been with WHO for more than 30 years. We definitely thank her for her service. And she plays a very crucial role in coordinating the metrics work and research work on healthy aging. We also have Louisa Degenhardt. Louisa is a professor of epidemiology and national health at the University of New South Wales. She's also the Medical Research Council Principal Research Fellow at the National Drug and Alcohol Research Center, also at the University of New South Wales. We have Stein Emil Vollset. Stein Emil is the director of the Center for Disease Burden at the Norwegian Institute of Public Health, and also serves as a professor in the Department of Global Public Health and Primary Care at the University of Bergen in Norway. And then our final discussant, Dr. Mohsen Naghavi. Mohsen is well known to all of you. He's professor of global health at IHME here at the University of Washington. And Mohsen leads very, very important work, especially on the causes of death analyses. The only comment I would make before I turn over to Steve is, this is truly an important part of the core mission of IHME, and we would want to make sure we get as many of you to comment, to make suggestions, to ask questions as possible. So please write down your comments, and with that, I'll call on Steve to give us the presentation. Steve?
Thank you, George, for that very nice introduction. What I'd like to do in this presentation is to highlight the use of the GBD to identify and quantify a series of health challenges. I'm going to do this in two ways. So first, by looking at both the level and trend in disease burden. And then second, to extend the presentation given by Theo earlier to look in more detail at some of the key deviations from the average epidemiological transition as measured by the socio-demographic index. So beginning with the level and trend in disease burden, this figure shows on the x-axis the all-age disability-adjusted life year rate per 100,000, and then on the x-axis, the all-age so the change in the all-age DALY rate between 2006 and 2016. I've labeled in this figure causes that account for a large disease burden in 2016, so above 2,000 DALYs per 100,000, and then those causes that have increased over the last 10 years. Now, as you can see, there are a whole range of causes related to aging. So this includes Alzheimer's disease, osteoarthritis, low back and neck pain, ischemic heart disease, and so on. And of course, this is not surprising given that we're looking at the all-age DALY rate. The question, and given the aging of the global population, the question is, to what extent are these increases driven by a simple aging of the population versus changes in the underlying disease rate? As part of GBD, we've examined this by decomposing changes in the disease burden between 2006 and 2016 into 4 different components. So in this figure, you can see the light green bars represents the change in DALYs between 2006 and 2016 that are attributable to the aging of the population. The darker green part represents the change due to the overall growth of the population. And then the yellow and red sections represent the change in the underlying rate. The red section represents the change that is related to risk factors. And then the yellow represents the change that's unrelated to risk factors. And you can see here the black dot represents the overall change in DALYs between 2006 and 2016 for that cause. We have all causes at the top of the figure, and then causes ranked by the change between 2006 and 2016. So the high-level finding here is that there are a number of group 1 causes towards the top of the figure where the increase in disease burden driven by population growth has been offset by very large reductions in the underlying disease rate. So that includes causes such as HIV, diarrhea, lower respiratory infections, maternal and neonatal disorders. At the opposite spectrum, so at the bottom of this graph, there are a range of causes where disease burden has increased substantially with aging of the population, as shown in those light green bars. But importantly, the underlying disease rates have only declined marginally or have stayed largely flat. So that includes neurological diseases, musculoskeletal diseases, so many of those group 2 causes. Now, what's also important, as shown in this figure, is the contrast between those conditions and other group 2 or non-communicable conditions, such as ischemic heart disease, chronic respiratory disease, which, despite the increase in burden with the aging of the population, have also been partly offset by declines in the underlying disease rate. Now, we can also see that more clearly. We return to the previous figure, but this time changing the y-axis to the change in the age-standardized global disability-adjusted life year rate. And we see those causes, again, related to aging, but this time primarily related to disabling conditions. And compared to the previous version, we see ischemic heart disease actually dropping off this collection of causes which represent a high disease burden, but also increases in the disease burden over time. Now, what this highlights, of course, is that the challenge of aging is not just due to a simple aging of the population, but that there are a range of key causes, such as Alzheimer's, osteoarthritis, for which the underlying disease rate is largely staying flat, or is only declining marginally, particularly compared to other causes of disease. Now, in this figure, you'll also see a number of other causes that are less related to aging. So this includes anxiety disorders, depression, migraine, drug use disorders, and so on. Now, I'd like to focus on 2 of these, as they also highlight the departure from the average epidemiological transition that Theo was presenting earlier. So beginning with drug use disorders, which is an excellent example of variation from the average epidemiological transition. So this figure shows here on the y-axis the log of the DALY rate due to drug use disorders, and then our socio-demographic index on the x-axis. The black line shows the average progression of drug use disordered DALYs with increases in the SDI. And it shows a general increase with increasing SDI. But what's most important of this figure is the pretty much incredible variation that we see at the same level of development, where the DALY rate can vary by more than 2 times at the same level of the SDI. Now, we can visualize how countries vary in that relationship in the following map. So this shows the difference between the observed and the expected rate, with countries shaded red representing those countries which have a higher observed rate than expected based on SDI. Dark blue representing those countries with lower observed rates compared to that expected by their level of SDI. We can see the very high rates of disease burden above that expected in North America, Australasia, Eastern Europe, parts of Western Europe, so the UK and Scandinavia, and then also parts of North Africa and the Middle East. Now, this variation across country actually becomes much more pronounced as we get down to smaller subnational levels. And in this map, which is work done by colleagues at IHME, shows drug use mortality rates at the county level in 2014. And here it's very clear that the drug use epidemic in the US is very focal in nature. So almost 15 to 20 times higher in Appalachia, and then also focal areas in Oklahoma, New Mexico, parts of Nevada, and California. And if you look at the map on the right-hand side of this slide, you can see that these represent incredible changes in drug use mortality over the last 35 years. So those darker shaded areas actually represent a 50-fold increase in drug use mortality over time, with a large part of that increase being driven in the last 10 to 15 years. So this highlights again, as has been said already this morning, the incredible value of doing high-resolution subnational estimates of disease burden. Now moving on to the second cause that I'd like to focus on, which is diabetes. This cause also, like drug use disorders, represents significant variation from the expected epidemiological transition. So here we see 2 to 3 times the variation in the Daly rate due to diabetes at the same level of SDI. A quite different pattern of the average relationship with SDI, so highest rates observed in the middle levels of SDI, with the rate declining as development progresses. Now, if we look at countries that are outliers from the average relationship, we can see the highest levels observed in countries in Oceania, parts of the Caribbean, Mexico, North America, and then also parts of South Africa, North Africa, and the Middle East. Now, of course, the direct disease burden due to diabetes is also only part of the story, as is evidenced by the GBD's work on quantifying risk factors. So this shows here in the darker shaded areas the fraction of the corresponding disease burden that's attributable to high fasting plasma glucose. So the direct disease burden, which I'm presenting so far, represents the square labeled there as diabetes. But you can also see the large fraction of disease burden that's attributable to high fasting plasma glucose for causes such as ischemic heart disease, stroke, and chronic kidney disease. Now, if we continue looking at the risk factor attributable burden, and particularly trends over time, this figure shows, again on the x-axis, the absolute disease burden in 2016, and on the y-axis, the change in the summary exposure variable or risk factor prevalence on the y-axis. And you'll note the position of high fasting plasma glucose on the top right-hand part of the quadrant again. But also above that, body mass index increasing even more rapidly, and of course that's a major driver of exposure to high fasting plasma glucose. Now, I'd like to now take a bit of a step back and look again at a higher level view to highlight a number of other emerging challenges at the country level. And that's by looking at the map shown here, which highlights the cause with the largest difference between observed and expected based on the socio-demographic index in 2016. So I'll highlight here Greenland, which coded in green here represents self-harm. And if we look at suicide mortality rates in Greenland, they're about almost 4 times higher than the next highest country. So highlighting that large deviation from the expected epidemiological transition. Other patterns to note here are the continued importance of the HIV epidemic in many parts of sub-Saharan Africa, but also importantly in Eastern Europe and also in North America. Remembering again that this is deviations from the expected based on SDI. A similar story for malaria, continued importance in sub-Saharan Africa, parts of Latin America, and then also South Asia. And then we can also note other regional patterns, so liver cancer being the most divergent cause in China, Mongolia, and Japan. And if we zoom in a little bit on Latin America, also interpersonal violence being the cause that represents the largest deviation from expected for those countries. And we can see that in more detail by looking at the variation in the observed versus the expected for interpersonal violence. For Latin America, having much higher rates of interpersonal violence DALIs compared to expected, but also in North America, Eastern Europe, and then also Southern Africa. So what I hope I've shown today is a small demonstration of how we can use GBD to identify a series of health challenges. Now, what these findings also highlight is a number of issues already discussed this morning in terms of refining both data collection systems and measurement of the GBD. So this includes the need for higher resolution geographic levels in terms of quantifying disease burden. And if we think about moving this to the extreme, that actually ends up where we're quantifying disease burden at the individual level. But a value, of course, is also linking disease burden to a set of the key health drivers. A third issue is to be able to distinguish disease burden by that which is addressable by available technology versus that requiring innovation. And here I refer to technology not just in terms of health technology, but also broader multi-sectoral actions. And the causes presented here, such as drug use disorders, emphasize the need for some of that multi-sectoral action to address the underlying disease burden. And then, as Trevor already mentioned in the first session, translating the work of the GBD into projections of what the future looks like based on those past trends and relationships with key drivers of health. Thank you.
Steve, thank you very much. That's wonderful. So we'll go ahead and get the discussants' comments, and then we'll open it up to the floor. Let's begin with Ritu.
Thank you. Greetings to all. Thanks very much to Chris and IHME for giving me the opportunity to start off the discussion on Steven Lim's excellent presentation that touched on the importance of population aging. Recall the green bars. I'm particularly interested in how GDB findings now and in the future can help best shape policies and also identify ways we can work together to improve data and measurement. I'm going to share 3 messages. The first is that we are here to celebrate. It is clear from GBD 2016 that the enterprise is reaching its goal to provide an outstanding global public good, rich descriptive and comparative data monitoring health, disease, and disability at many levels. The importance of using available data and providing estimates where data does not exist is vital so that we can discuss if health of populations are getting better, if improvements are inclusive, and whether countries are on track to achieve what countries themselves have agreed to do. Accountability also tells us where we can most likely learn from and where we can pay more attention to. GBD 2016 certainly provides the most up-to-date evidence on trends, drivers, and projections of population health. And over the past 20 years, I have witnessed how this information is widely used by decision makers as well as researchers, advocates, and other health professionals. However, the headlines from the 2016 edition are sobering. Last week's Lancet articles note that despite mostly stagnant age-standardized rates, the absolute number of years lived with disability from non-communicable diseases has been growing rapidly across all sociodemographic index quartiles. partly because of population growth, but also due to aging populations. And the slower progress in addressing non-fatal compared with fatal health outcomes and aging populations make YLDs an increasingly important component of global DALYs. Theo's presentation also showed in some high-income countries with advanced aging, YLDs already make up more than half of the total burden in DALYs. WHO also recognizes that the prevalence of disabling diseases generally increases with age, and our civil society partners, such as HelpAge International, confirm that functional loss is what older adults and their families are concerned about. Our recent World Report on Aging and Health cites data from the earlier GBD findings and agrees that if nothing else changes, health systems will face increasing demand for services during the second half of life that can be costlier than existing interventions during the first half of life. But we also know from very recent IHME analyses of development assistance on health that there is a mismatch on the flow of funds to different age groups in comparison to burden of disease, with younger age groups receiving disproportionately more. So my second message is that an important policy response to population aging and health is to take a life course approach that connects the first and second halves of life and that promotes healthy aging. This is what WHO member states agreed to in 2016 in its first global strategy on aging and health that is also connected to 6 regional frameworks. The goal of the strategy is to optimize functioning that enables well-being in older age at any level of impairment or disability. As there is no typical older person, some people will require aids and support, whereas everyone will benefit from a supportive environment. The strategy has 5 components. The first is national commitment and policy coherence. The second is developing age-friendly communities that benefit all ages. In fact, we have a network of more than 500 age-friendly cities, and Seattle is one of them. There are 2 core to WHO: aligning health systems to the needs of older adults and ensuring long-term care, whether at home or in institutions. To improve health systems response, it's not only about scaling up access and quality to existing services, it's also that there's growing evidence that it's better coordination and management of services for older adults. So to complement existing protocols to manage NCDs, we have just released new guidelines on integrating care for older people that covers 6 community-level interventions to manage declines in physical and mental capacities and specific geriatric syndromes. A novelty is it includes approaches to support caregivers. The final component is better metrics monitoring and research, and we want to collaborate and have more data and information on older adults and their health by 2020, ideally for 80% of our member states. This includes filling gaps that GBD 2016 recognizes, such as in the severity distributions across sequela for most diseases in the YLD literature. But to implement this strategy, we need objective assessments about the probable benefits of applying different packages of interventions across the life course that are inclusive of all ages, not just up to the age of 69. GBD has an important role. This will also support what interventions are included by different countries as they update what is included in their universal health coverage packages. In contrast, we know from the 6 middle-income countries in the WHO SAGE study on adult health that households with adults over the age of 50 experience significantly greater financial burden to health than households who do not have older adults. So drawing on GBD, we are keen to enable evidence-informed discussions with policymakers. So for my third message, a few areas to consider where better data and monitoring techniques can improve. Clearly, we need better cause of death data on older adults. Also, we need more information on the severity distributions and disability weights in a neutral environment, but also in people's actual environment. We are looking into real-time data collection devices that provide a whole new approach to analysis and understanding of the continuum of functional loss. This innovation seems in the spirit of GBD. Concerning granularity, we want to encourage others to adopt GBD's 23 age groups by sex, as older adults cannot be lumped and reported into one category, such as 60 plus or 65 plus, which still is the norm. An important opportunity exists to influence the new UN City Group on age and age disaggregated data, sponsored by the UK Office of National Statistics, that will be launched at the UN Statistical Commission next March. WHO and several other UN agencies have put this together to engage countries to consider not only aging and health data, but also connect to aging data in other sectors. Many of us at WHO are keen to develop a new World Health Survey that would also oversample older adults. This could further enable and explore how we can build synergies to also better estimate healthy life expectancy directly from surveys. There is a family of health and retirement studies that is keen to work with us to improve standardized measures of health states, sort of within the skin and also within one's context. This includes the new longitudinal aging study survey in India, LUSSI. There are some specific analyses we could also be keen to collaborate on, such as through up-to-date assessments of non-fatal health outcomes on the need for care or care dependency. Finally, we are keen that IHME helps develop a micro-simulation tool for countries with extensive subnational data. This could use the GBD input data and projections and tailor it for specific country situations. To conclude, I remember GBD 20 years ago, the so-called small academic effort. Even so, I believe Atlas shrugged in 1997. Now, 20 years on, GBD is a tool for surveillance and monitoring of global and national health goals. The approach to collaboration and peer review, somehow a mix of crowdsourcing and Wikipedia. I think Richard mentioned the human genomics as well. I think it itself is an innovation. I am optimistic that we can strengthen collaboration, supporting countries to make tremendous impact between now and 2030. Thank you very much.
Thank you very much, Ritu. Now we hear from Louisa.
Thanks, George. And it's a pleasure to be here today. I've been involved in the Global Burden of Disease study since 2001. And I think on my topic, I will be talking about alcohol and illicit drug use, both use disorders, but also the health consequences of their use. And I think that they are an excellent example of emerging challenges, prevalent challenges, but also particularly for illicit drug use. I guess my challenge has been getting illicit drugs to be recognised as an important cause of health loss, and I think that's increasingly emerging in the Global Burden of Disease project. So 3 points around what we know to date based on what the Global Burden of Disease project has shown us around alcohol and illicit drugs. Drugs are my primary focus, so I'll give them a bit more emphasis. Firstly, as currently estimated in the Global Burden of Disease project, alcohol and illicit drugs are important causes of burden. They're thought to be responsible, if we trust the estimates, for around 8% of all health loss in men and 3% for women. Alcohol is the 7th leading risk factor globally, and it's the biggest risk factor for adults aged 15 to 49. What we've also seen is that these risk factors vary over time, and in that I mean both the exposure and the risk of negative outcomes of that exposure. We've seen increasing prevalence, as Steve mentioned earlier, of drug use disorders and the burden due to drug use disorders. That's particularly driven by opioid use disorders. We've also seen increasing burden due to alcohol use in many countries in Asia, and that's both among women and men. What we've also seen is that the increasing burden due to drugs is increasing at a greater rate than alcohol. Since 1990, burden attributable to alcohol has increased by 25%. That for drugs has increased by 2/3. The third point is that these, both drug use disorders and the consequences of drug and alcohol use, vary substantially geographically. And as Steve mentioned, a lot of this doesn't have anything neatly to do with the SDI. There are a lot of other factors that affect the prevalence of alcohol use, of illicit drug use, and also affect how risky it is when you choose to use those substances. In terms of 2016, the greatest burden attributable to alcohol was in Eastern Europe and Sub-Saharan Africa. But it was high-income North America and Eastern Europe who had the greatest rates of drug attributable burden. And indeed, in North America, high income, illicit drugs are now greater causes of burden of disease than alcohol is, and that's been driven by the substantial opioid dependence problem. Not all exposures are equally risky. It doesn't mean the same thing to inject drugs in one country as it does in another. So the extent of HIV burden due to injecting drug use is much higher in countries in middle SDI regions than it is in high-income countries or low-income countries. The risks of contracting HIV vary substantially by country, and that is related both to the availability of effective interventions to reduce harm, but also background prevalence. So in terms of what do we need to do in the future to improve data collection, measurement, and to inform policy responses to alcohol and illicit drugs? Firstly, I would argue, yes, everyone says that we need better data, but actually what I would point I'd like to make is that we need to do a much better job of capturing burden due to illicit drug use. There are many consequences of illicit drugs that are not modelled in global burden of disease, and yet we know that there is increasingly impressive evidence to justify us thinking that there's a causal impact of drug use on those outcomes. That particularly includes unintentional injuries, but also intentional injuries, physical assault, sexual assault, and homicide. There's also increasing recognition that we need to look at the complex interplay between alcohol and illicit drug use and the potential mental health consequences of that use. It is not a simple association, and there's likely to be a complex bidirectional relationship, but that really needs to be better investigated. Additionally, what has not been modelled to date is the impact of illicit drug use on others. The concept of harm to others has been an explicit focus in estimates of tobacco attributable burden, and around 1/8 of tobacco burden is due to the effects of secondhand smoke. We know that there are significant risks in terms of both intentional and unintentional injuries related to illicit drugs, and that needs to be better captured. Similarly, more work needs to be done to explicitly model the potential impact on unborn babies and infants for people who use drugs in a heavy manner during pregnancy. In terms of data collection, as I mentioned before, yes, we need to do more. Surveys are not necessarily the best way to get a good handle on more stigmatised and infrequent patterns of illicit drug use. We need to take advantage of the increasing availability of administrative data collections, not only to get a better handle on the prevalence of alcohol and drug use disorders, but also to think innovatively around how to link those data and look at the association between those exposures and negative health outcomes. Additionally, we need to recognise that alcohol and illicit drug use are not distributed evenly in the population. GBD models things according to age and sex, but there are important subpopulations within the general population where we know that use is highly elevated. One example of this is Indigenous people who in many countries have highly elevated rates of both alcohol and illicit drug use, and that includes Australia, Canada and the United States, but other countries as well. And finally, I guess in terms of thinking about the potential policy implications of what we even know to date. For drugs, the predominant health policy or government policy response has been to focus on efforts to prevent use. I think what GBD is very clearly shown is if we were judging the GBD statistics as an evaluation of the success of those efforts, we've failed fairly significantly. This is not surprising because the evidence for prevention efforts for illicit drugs is very weak, and there's not a whole lot of evidence supporting particularly school-based drug education and similarly. So I think there's a real need to shift towards a focus on preventing harm. We know that there are many interventions which will prevent and reduce significant harms related to illicit drug use. That's both for infectious disease but also effective treatments for drug dependence. And I think we need to really increase a focus and a push towards really ensuring that they are rolled out much more than they are today.
Excellent, Louisa. Now we hear from Stein and Emil Vollset.
Yeah, it's a great pleasure for me to be here celebrating the 20-year anniversary of GBD. For many years I admired GBD only from distance. Now I'd like to thank the organizers for inviting me to share some of my experience as a collaborator and some viewpoints on how to perhaps improve GBD in the coming 20 years. This year in Norway, we have formally established a Center for Disease Burden at the Norwegian Institute of Public Health. We have been collaborating very closely with IHME and GBD for the last 3 rounds. We have now published reports in Norwegian for GBD 2013 and 15 and worked closely with researchers across our institute so that GBD and the GBD Norway results are now quite well known and used by the Ministry of Health, the Directorate of Health, responsible for advising the ministry, and many others. The press and media are also very keen on writing or airing the results. I think this is because they see GBD gives a good overview of health status and risks, both for Norway but also globally. Myself, I also use GBD in teaching medical students and other health professionals, and I know many colleagues who do the same. There is some opposition and skepticism to the GBD results on how disability weights are estimated, on the use of a common global set of such weights and common reference for computing years of life lost and imputation of missing data. And some of the skepticism just arises because of the sheer distance from us to the center in Seattle. However, we are now stepping up the collaboration with IHME. In the coming GBD 2017 round, we will be doing subnational burden of disease in Norway for the 19 counties, or fylke, from the smallest in the north, which is Finnmark, with a population of less than 100,000, to Oslo, with a population of above 600,000. One worry that has been raised to me with this, and which I sympathize to some extent with, is that even for Norway, which is a data and health data rich country, we do not have adequate and updated data across the counties. This holds particularly for risk factors, but also applies to many non-fatal causes of disability, including, for example, musculoskeletal disorders. The worry is then twofold. First, that we will not get the cross-county variation right, but second, that the maps and complete GBD series of estimates will obscure the fact that the data gaps are still many and large. This could, some say, reduce the push for new and improved data collection. And new and regularly updated data are, of course, the best way to better inform local level policymakers and the public with relevant health and risk information. So at this point, I would like to give a reminder that GBD, in addition to being the premier machinery for producing complete and best available estimates for health and risks across the globe and also at the global level can be used for another important purpose. GBD, with its very large repository of health data, is also a great and so far underutilized machinery for identifying data gaps or lacking data. From this, one could produce an overview of diseases and risks, country by country, time period by time period, and for subnational locations of where data are either totally lacking or where they are weak. And this could guide investments in data collection. Countries should also be encouraged to study quality of life and severity of non-fatal disease. For example, countries may have estimates on the prevalence and incidence of important diseases, but only rarely on the distribution within each disease or condition from mild to moderate and severe, or final categories on how patients fare in these severity groups. However, there are also good news on the data collection side. For the first time in almost 2 decades, we are now planning a survey with in-depth personal interviews to assess prevalence of various mental health conditions, and this happens with the support of the Ministry of Health. I would also like to add a comment on a phenomenon that we could call data lock-in. This is the increasingly time and resource-consuming process of acquiring data from health registries and other sources, data that are already collected. And this is true even for very legitimate purposes within our own National Institute of Public Health. And I think we need help on this and join forces internationally so that we can push for a common ground on making data available. We must find a reasonable balance between privacy concerns and use of health data for the public good. I think often much could be gained just by streamlining the administrative routines in and among the various and many institutions and legal bodies responsible for data governance. And I know that France has made great progress in this area in recent years. I will also use this opportunity to say a few words about the WHO Europe Burden of Disease Network that Claudia Stein may add something on in the next session. The network started a year ago and met again this year. It's a network of experts from 12 countries working with WHO and IHME in the lead to produce as one of its first products a new burden of disease manual that I think will become very useful across the collaborator network of GBD. And the WHO network is also a useful and inspiring, very inspiring forum for discussions on how to make burden of disease initiatives across Europe comparable, also for various levels of collaboration with GBD and IHME. Scotland, for example, adhering to much of the, what I would say, GBD data infrastructure, just published their own burden of disease estimates based primarily on registry and e-health data. In closing, I look very much forward to continue the GBD collaboration. In my opinion, GBD provides the best framework and standard for comprehensive national and subnational health and health risk analysis across the globe. And so congratulations to you all. Thank you.
Thank you very much. Now we turn to Mohsen for the final discussant.
Thank you so much. And it is my pleasure to be here and talk about two topics in behalf of team that we are working together in IHME in the global burden of disease. One is causes of death and one is subnational estimation. Please come back and look to the data from your country. You cannot see big number of the deaths due to the overdoses. There is no big number in the many countries that they have VR data, vital registration data for the drug overdoses or drug use disorder. Mainly, many countries hide this data, including many developed countries. We published in the GBD capstone paper this year that US usually 70% of the data that is drug overdoses deaths hidden in the unintentional poisoning. That is the cause that many deaths due to the overdoses goes in the different countries, including US, Russia, all Western Europe, and all Eastern Europe. In GBD 2015, we understand this problem, and we extracted this data. In the paper, you can see we put a graph that unintentional poisoning is very low in the children. It's going up a lot in the young age and middle age, and then going down. What is this unintentional poisoning in the young people? Is not unintentional. It's something that happened intentionally. This is the problem that maybe for the next year or next GBD, in GBD 2020, we can find other emerging problems that hide in the data from the different countries. And we can see, same as this problem we have in the Alzheimer. Alzheimer in many, many countries for many, many years hidden in the some intermediate causes like pneumonitis, like lower respiratory infections, like stroke and other things. And now, after working with the data, with the big data set that we have, we understand that how we have to handle this type of problem. And maybe in the next year, because we are now looking to the multiple causes of deaths and multi-diagnoses, hospital data, we can find a big number of the, for example, road traffic accident, and that other causes in the road traffic accident is using alcohol, using drug, and some other thing. Then maybe in the next year, we have a better estimation for these causes. This was the point that, and also, if this behavior is not globally, this behavior change country by country. If we try to find different pattern in the country, maybe emerging problem in the global health or in the public health is different country by country. This was the part that I wanted to talk about emerging data. Another thing that emerging problem. Another thing that I wanted to talk is about estimation of the subnational. Data is a power, and this power for many years hidden in the drawer and shelf of the public health people. The most important thing in the GBD that I believe that this is very important is that GBD result is a public goods. It means that everybody can have access to this data, can access to this result. And most important thing that can start a challenge for the change is a transparent and understandable descriptive report for the people. When we can present situation in the different country, in the different state, in the different districts, what is the situation for the people. They can ask for the change. And this is the very important topic for the GBD. GBD can be part of challenge for the democracy, because passing information to the people make a change, make a request, and this is a big mission for the GBD, I think. Thank you.
I really want to thank my colleagues up here for staying on time and saving us quite a bit of time for the discussion. We have more than 18 minutes or so to take your comments, your questions, your suggestions. And what I would suggest is please come up to the roving microphones, tell us who you are and your affiliation, so that if there's a follow-up question, we can very easily find you to either inform you or get more information. But we really want to engage you in this. So I see there's a gentleman on the left. I'm sorry. My left is your right. You're ready. Go ahead, sir. You're right.
Hello. Good morning. I want to have a thank you to all the leadership. I'm a collaborator, and I have an honor and privilege to contribute very little, but still be part of a very amazing journey. Thank you, Chris, and all around. Now, I am an outlier in the collaborators. I'm a surgeon, so it is very out of context to be here. However, I do care about my patients and the world I live. I am very thankful about Steve found what we found. Our country is dying because of overdose and because of obesity. That's about it. Cancer is increasing, but it's related to aging. I have an NIH founding lab as well, and since I have leadership position in 2 universities, I took a fellowship in policy making that I complete. Policy making is extremely complex in this country. It includes 3 secretaries, about 14 going to 16 institutes. It's a business that is going to pass $4 trillion in direct cost. So when you want to change policy here, it has infinite ramifications. And the only way to do it is what we think it should be done. At the American College of Surgeons and different societies, we form a coalition, we form a foundation in which we go and knock the door every 6 months at Capitol Hill, and we talk to our congressman, we talk to our representative, and we just want one goal, one disease, one change, and we follow that. Politicians doesn't understand all this. They want only, how can I impact in one thing? How can I change that? Yeah. And that's what we have to do here. Every single collaborator here, I challenge you not only to know how to change and make policy in your country, but identify 2 or 3 goals for each year that really can change it. And get involved, get committed, get it done. Don't sit down and read the data and say, wow, what a work. We need action. Thank you.
Sounds very good. Simplicity and don't try to boil the ocean. That's what I got from that. I see a gentleman on your left.
Yeah, thank you very much. George Patton, University of Melbourne. My question is for Steve and perhaps Louisa. And it's a question about the SDI, Steve. It's been a terrific innovation within GBD. And it's brought together 3 traditional measures of indicators of international development. And it seems to work really well when we're actually talking about type 1 conditions, but it seems to work less well when we're getting to some of the new morbidities and NCDs. And I'm wondering if something is missing from it. So when I look at that map of drug overdose deaths in the US, I see a picture which probably reflects socioeconomic inequality in the US or relative to the rest of the country. So I'm wondering, is there something that needs to be added to the SDI, or is there a need for a different measure that is going to be more sensitive to some of these new morbidities?
All right,
You're more of an expert on SDI than I am, but I think the drug overdose example, I think, is a really interesting one where I think some specific work needs to be done to look in much more detail and with greater nuance around what are the drivers across countries, but also within countries. I think inequality is definitely going to be one of those things, but I think also having an increasing awareness of other factors, and they can be structural factors and system level factors that affect availability of drugs. And I think that America might be a bit controversial for Mohsen, but I think America is really experiencing the consequences of very wide-scale prescribing that probably in some instances was not advised prescribing of opioids. We know that we've got all of the data on utilisation, so exploring those kinds of variables in greater detail I think would be really important.
Yeah. Thanks, George, for your question. I think in part the answer to it is, we could incorporate, for example, measures of inequality into that measure. For me, a better approach is to get down to measuring things at that more precise scale. And actually, as I flagged in my last slide, ideally getting down to individual level measures of association, which would, I think, tease out some of the issues you've raised.
I think I will only very briefly add that this also poses a unique research opportunity, particularly for research funding agencies, the MRCs, the CDC, and NIH. I mean, an underlying assumption is that countries within a specific SDI should be expected to behave fairly similarly, but you see almost a twofold or greater variation, and maybe asking the question, what are the principal drivers of those variations within SDI that can help us identify what other measures or metrics could help refine it? So I think a very, very important question. Let's go to someone already has the mic. Please go ahead.
I'm Michael Phillips from Shanghai. My question is related, we're emerging challenges. My question is, where do we want GBD to be 20 years from now? We've been watching this fantastic evolution of GBD, but it's been sort of haphazard. Some people take it up, some people don't. It goes this direction, that direction. But 20 years from now, the next 20 years, do we have a target? Is there a target in the leadership, or every country kind of does what they can do with it? Because if we want to get somewhere, we need to have a target, and then we can have a plan to get there. And I'm wondering if the speakers or if the leadership of GDP actually has a target. Where do we want it situated in terms of WHO, in terms of country policy making? Is there a direction we're going?
I'm going to ask my colleagues to comment very briefly, but please don't sit down yet. I'm going to challenge you on one of your premises. I think from what we heard this morning, very few people would say this evolution has been haphazard. But honestly, you sound like you've been thinking about this a lot. What would be the one suggestion that you would have for us? And then I'll ask my colleagues to comment.
I think that we need to be a little more proactive. I think we're going in the right direction in terms of interaction with WHO. WHO has political leverage, and in order to enact our data to get those policies, we need to have political leverage both at the international and, for example, Norway example, at the national level and then at the subnational level. So I think we need to get a closer relationship with the politicians and aim at that in some way without being bought by them. And that's often a difficult challenge.
Excellent. Maybe Mohsen would like to comment.
I think that we have to come back to the M's poem that she read. I think that journey is much more important than the destination. This is the topic that I love in GBD. GBD is a river, is not a mountain. GBD 2015 completely different with the GBD 2013 and GBD 2016. Every year we learn many points, we learn many challenges, we fix the challenge, we improve the data, we improve the result. This is the journey. We are not a mountain, we are a river.
All right,
Okay,
please
I
go
think
ahead.
it's my turn. I'm Karzan, a collaborator from Iraq. My question is for Professor Mohsen. You mentioned that this is a reveal of covered data from public sectors. In Iraq, actually, we are facing this problem of unrevealing those, bringing those data out from the governmental sectors. They are not willing to give the data in order to publicize it and make it public. So what's your suggestion in this case? Do we have to move around and try to get the data, or we should stick into the official papers? Thank you.
Both.
Both, okay.
Yes, we have a very good memorandum with the Ministry of Health and Ministry of Health of Iran. They will accept to share the data with us, but we know that in the Iran or in the many countries, all the data is not in the hand of the Ministry of Health. Many data is in other hand. Then we have to get data from Ministry of Health, from different university, from state, from province. We have to get data because GBD is alive by the input data. It is very important.
All right, thank you.
Let's go to the right side.
This is a question to Madam Ritu. When she was mentioning, I am Dr. Hamdani from Sri Lanka. She was mentioning about long-term care on elders, so which is actually becoming a major focus on developing countries, which due to the socio-demographic transition. But is there much awareness created regarding long-term care? That is where the question rises up. And though few countries have few policies being placed, but actions are not being taken up. So ADLs, IADLs are not being known even by the policymakers. So that is one of the challenges which is going to be like in future.
Okay. Thank you. I think one of the most important aspects of the global strategy that I mentioned was the inclusion of long-term care systems as part of the commitment that countries made. And it's the first time that that was made at a global strategy and an accompanying WHO Assembly resolution. But there are many issues. I think you've raised a couple of them. What we're trying to encourage countries to do is to actually account for all of the informal care that is currently provided and to consider the quality or lack of quality of that informal care and who is providing the care. Often it's women who are unpaid. And the strategy and the approach to work with countries and within each region is to consider when you have a better understanding of costs, you can actually look at investments to offset more expensive services that are provided, whether it's in hospitals or in other settings, and to think through what are the approaches to support caregivers. So it's a systems approach. For some countries, they've been experimenting. In other countries, they're just beginning to look at different approaches, and there are several countries that have made some advances outside of the high-income countries. So I'm happy to talk about that more during the lunch.
Great. I believe I'm being asked to summarize in 5 minutes because we have only 5 minutes left. But this has been such a rich discussion that rather than take the 5 minutes to summarize, I'm going to give only the 3 people standing. You have just half a minute to briefly say what it is that you wanted to say, and then I'll take the last minute to sum up very quickly. So go ahead, sir.
Yeah, I'm Troy Jacobs. I'm a pediatrician at USAID and George Washington University in Washington, D.C. I want to relate the last panel to this panel's discussion in that when we're thinking about the sort of transition that we're seeing epidemiologically or demographically and taking on these new issues in terms of non-communicable diseases, there is important variation that we are capturing, with SDI in terms of quality, but if we think about sort of the robustness of this transition, it actually varies within country. I mean, so you have fragile areas, urban slums were mentioned earlier, and what we are knowing from the science is in fact that there are important epigenetic and environmental changes that actually impact the course of chronic diseases, non-communicable diseases. And so I wonder if there's actually further work that we need to do in terms of the GBD in capturing some of this important variation as countries transition. The other thing is that, I mean...
I'm going to give you only that one,
yeah,
please.
okay.
So I'll have Steve make a quick comment. Just the importance of going beyond traditional, look at the epigenetics and the causes of variation.
Yeah, in short, to agree that I think what we do need to do is go beyond fertility, education, income, and start to look at other drivers of health and how they can explain variation across countries and time.
Great. Please, very short.
Okay, hi.
Thank
I'm
you.
Jeff Duchin from Public Health here in Seattle, King County, and the UW. And my question is, are there examples of how global burden of disease and related activities have influenced the uptake of the recommendations in the international health regulations or the global health security agenda for developing national and subnational public health infrastructure?
We have many examples, including Brazil, very good, Mexico, and many other countries that now in the state level, they are using our result for the health planning.
I would also very briefly add that keep your eyes open because the NIH is also very, very interested in finding ways to work with IHME to make opportunities available for subnational data analysis. Very, very good question. Last comment, please.
Thank you. Seeing that there's talks in terms of collaborating with the WHO and others, and that there's a flair and appetite to deal with, to address NCDs, I see that a partnership for healthy cities has been launched with the WHO and the Bloomberg Philanthropies. I see that South Africa is amongst the cities that have been identified for that partnership. It's about 40 cities, and one of them is Cape Town, in fact. And that's one of the cities where we don't only need to go subnational in South Africa, but deeper than that, at county level. And I think that provides an opportunity to go down to that level. So the partnerships for healthy cities managed by WHO provides an opportunity for IHME to get involved at that level. Thanks very much.
Great. Thank you very much. I'm very mindful and I want to be respectful of your time, but I also want to make sure that we don't shortchange you. So I'm going to commit my colleagues up here to working together to produce a summary document that highlights, I have 3 pages of notes, all of it really very important from the comments you heard and the suggestions you made, and we'll do our best to make this available as open access, either published or at the IHME website. So please join me in thanking our panelists and thanking all of you. And now now yield back to lunch. Is that it? Okay, I'll yield back to lunch.